So good morning. I think we should get started. Good morning and welcome, everyone. Let me get my glasses. My name is Doris Fildor. I am the Health Systems Director for the Alzheimer's Association, and I am very proud and excited to welcome you today to the Alzheimer's and Dementia in Communities of Color Symposium. So this has been a joint effort between the Alzheimer's Association New York City chapter and Downstate Health Sciences Center, and it is something that has come together as a work of love and of many hands. So I really want to thank the planning committee who put this all together, as well as Dr. Berger, who is also a member of the New York City chapter board. So just a little bit of word about who I am and what we do at the Alzheimer's Association. We are a national organization. There are 74 chapters nationwide, and I am very proud to be working with our 7 chapters across New York State. And in my role, it's really to work on developing our relationships with hospitals and health systems and providers to see how we can work together to increase early detection, to raise awareness around dementia risk and promote risk reduction strategies, as well as to improve care for people living with dementia. And this is a work for me, but it's also personal because I lost my mother to Alzheimer's around 5 years ago. And this is kind of a full circle moment because I grew up not far from here on 46th Street, and it was a journey for us to find a doctor to care for her whole self. As a woman, as a diabetic, as a leader in the church, we really struggled to find a provider that would listen to some of the concerns we had. It was a journey to change that dynamic in the relationship where I was planning and making appointments, and she didn't want to necessarily listen all the time, but we figured it out. And it was something that really made me grow in love for her, as well as love for my father, who was really the primary caregiver for her. So I did as best as I could, but he was there day in and day out. And we went through the journey that many people go through in terms of understanding even what this disease was. It was nothing that we grew up with. It was nothing we were familiar with. I worked in health for a long time. I was out in the community doing HIV/AIDS presentations and maternal child health presentations, but I had never really delved into aging and what that meant. And one of the biggest lessons I learned is that aging happens every day. So even though you're 15 or you're 20, you're aging every day. And everything you do today can impact what happens later on. And there are some things that we also have no control over. And that's when we turn over to our trusted providers, looking for that guidance, looking for our social workers, looking for that support for the next step. And I'm really excited today to hear from our panel of experts around how they're doing this work in Brooklyn, and really looking to build that partnership, because what I also learned on my journey is that the community plays a huge role. Having a church, having different providers that are not necessarily health providers, but community providers, community liaisons, community leads, gatekeepers that are able to provide support, information, and really a safe space for you to decompress is really important, as well as understanding that where we eat and where we live are huge determinants for our health outcomes. So really excited to have a conversation in the community, with the community, as a partnership between health systems as well as community leads. So the Alzheimer's Association leads the way to end Alzheimer's and other dementia. Our work includes global research. As I mentioned, it includes risk reduction, early detection, quality care, and support, overall for the goal of a world without Alzheimer's and other dementias. So our work is all-encompassing, looking at what we can do to reduce risk, what we can do to improve quality of life, and what we can do to advance knowledge and research around this devastating illness. So to that end, we have gathered some amazing leaders, both from our internal resources and our community leaders, such as Dr. Reinhardt and Dr. Reintz, our leaders at Kings County, and as well as our first leader to talk today, Dr. Berger. So I met Dr. Berger through a colleague out in Texas, and I'm just going to say a few words about his background and history. Dr. Berger has 25 years of healthcare leadership experience at several academic institutions, and he currently leads the University Hospital at Downstate, its inpatient, outpatient services, accountable care organization, community health centers, home care, and other related entities. In this role, Dr. Berger provides operational and fiscal oversight for UHD and oversees the development and implementation of hospital-wide policies and procedures that promote quality patient care and patient satisfaction. As I mentioned previously, we are very grateful that Dr. Berger also serves on our board for the New York City chapter and are pleased to be partnering with him and his team today. So thank you all for being here, and Dr. Berger.
Good morning. Thanks, Doris. Appreciate that introduction. And for those of you in the auditorium, we purposely redid all the chairs in purple just in celebration of this event. As Doris mentioned, I am a member of the New York City Board of the Alzheimer's Association because to me, Alzheimer's is personal. My wife's family has Alzheimer's in multiple generations. Her grandmother passed from Alzheimer's. Her father passed from Alzheimer's. And Alzheimer's and other related dementias are a spectrum. And they were on this spectrum where they became extremely violent. So her grandmother, who was living with her aunt in Florida, had to be placed in an institution because she threatened my wife's aunt, who was her grandmother's daughter, with a kitchen knife. Think about that. So she ended up being institutionalized for the remainder of her life because she was obviously had become violent and needed to be medicated. My wife's father lived with us for a period of time in Houston, and it became unsustainable for him to be in our home. And we were very fortunate that there was a great memory care facility in Houston, and we placed him in the memory care facility. And the hardest part, my wife would visit him obviously every day, the hardest part of visiting him was every single time my wife went to see her father, he wanted to know where his gun was because he wanted to end his life. Every single time she visited. So dealing with dementia varies across families, the presentation varies greatly, but the statistics are devastating. Currently, there's over 6 million Americans dealing with dementia. 1 in 3 people over the age of 70 will pass either from or with Alzheimer's or some form of dementia, more than cancer, more than heart disease. But we don't hear about that statistic. We hear about cancer and donating to cancer and cancer care. We have cancer hospitals. One of the biggest hospitals in New York City is Memorial Sloan Kettering. I trained at a cancer center, MD Anderson in Houston. I think there are 50 NIH designated cancer centers throughout the country. Do we have an Alzheimer's center of the magnitude of Memorial Sloan Kettering? Clearly, we don't. Same thing with heart disease. Multiple heart hospitals throughout the United States dealing with heart disease, dementia, and Alzheimer's is at least, if not more, significant in our population, and we don't have any of those institutions to coordinate care. And the answer is why? The question is why. The answer is simple. It's about the money. Where does the money go in this country in terms of health care? It goes to cancer care. It goes to heart disease. It doesn't go at the same amount to dementia care and Alzheimer's care. So we need to educate our population. We need to really advocate with our politicians for more support. And that's why symposia like these are so critical. And just a final statistic, and why it's important in our population, the population that we take care of at Downstate and the population in this community around Downstate. Black older Americans are twice as likely as white older Americans to develop and suffer from dementia. So it's particularly important to our community, and it's particularly important to have these type of symposia to talk about the issues of Alzheimer's and related dementias in populations of color. So I want to thank the Alzheimer's Association for coordinating this event. I want to thank the speakers in advance, and I want to thank you for allowing me to be up here and share my story.
Thank you so much, Dr. Berger. And again, welcome to everyone here in person and online with us via the live stream. My name is Michelle Diskin-Greco. I'm the Senior Director of Programs at the New York City chapter, and I'm thrilled to be here with you today. There are 3 things I want to do in the next couple minutes. First, I want to thank you all for coming. Secondly, I want to thank Downstate for being such an incredible partner and pulling together this conference. We were really so pleased to have such a great collaborator. We came up with this idea together just over the last number of weeks, inspired by the visit of Dr. Carl Hill, who you'll hear from in a few moments, who's going to be in town, knowing that we wanted to do something meaningful on the ground here in Brooklyn at a place like SUNY Downstate where they're really walking the walk in terms of dementia care. So thank you all for coming. Thank you to Downstate. And now I have the pleasure to introduce you to Dr. Carl Hill, who is here with us today. I'll also let you know you're going to hear a lot more about our programs and services at the end of the conference. And during the break, my one plug before that, we have a lot of great community agencies that are represented here today and some of the other CADs here around the city. So please stop in to the tables, take information and resources, because in my Director of Programs hat, one of the best things we can all do is connect ourselves to as much information and education as possible. And with that, it is my pleasure to introduce Dr. Carl Hill. Dr. Hill is the Chief Diversity, Equity, and Inclusion Officer for the Alzheimer's Association, overseeing strategic initiatives to strengthen the association's outreach to all populations and providing communities with resources and support to address the Alzheimer's crisis. In this role, Dr. Hill is responsible for driving association-wide messaging and mobilization efforts addressing systemic health inequities in treatment, clinical trials, and research. He also develops cross-functional partnerships to advance Alzheimer's awareness efforts and to deliver disease education to those who are disproportionately impacted and underserved. Dr. Hill previously served as the association's Vice President for Scientific Engagement, and prior to joining the association, he served as Director of the Office of Special Populations at the NIA, where he led the development of the NIA Health Disparities Research Framework. He earned his PhD from the University of Michigan School of Public Health, and he holds a master's degree in public health from the Morehouse School of Medicine and received its Distinguished Alumnus Award in 2019. We are thrilled that Dr. Hill is here today to speak to us about the power of partnership in the pursuit of justice and equity in dementia research, care, and support. With that, Dr. Hill. Yeah. Let's find it here. It's a, I don't know where it is. Excuse us. Thank you.
All right, well, good morning, everyone. Good morning. All right. Early morning, and I tell you, I'm excited, because I had a chance to ride over from Midtown into Brooklyn, and I've been telling everyone this morning that this is the deepest that I've ever been into Brooklyn, and I'm a big Spike Lee movie fan, so I saw landmarks and things that I've only seen on the screen, on the movie screen, and passed right by them and just had a real sense of community. Just overwhelming to be with you here in person. So just really excited about this opportunity, and thank you, Dr. Berger, for sharing your insight and for making this happen, and Michelle so much for the introduction. Just really thrilled to be in this space and to be able to talk a little bit about community and partnership, right? And so I titled this talk, Unforgettable, and I'll link that to something later in the talk. But really, thinking about things that we can do, to address the disparities. That's the point I am in my career and with the Alzheimer's Association. We know, like Dr. Berger mentioned, that there are disparities, but there are opportunities for us to do things together through this vision of partnership. And so I'll talk a little bit about that. So let's see if I can. Got it. Okay. All right. Thank you, Doris. Thank you so much, Doris. And so I'll just kind of start where this journey began for me. It's mentioned in the intro that I finished the Morehouse School of Medicine Master in Public Health program, and being here in this institution, I tell you, it just gives me chills, because I remember my time at Morehouse School of Medicine, which is an academic institution in the community that's trusted by the community, and so just being here this morning and walking around, really made me remember my time there, and this all came together because of the community. Really the issue at the disparity at stake way back in 1995 was that there were very few African Americans in the field, Black African Americans in the field of public health, right? And at that time, the phrase was minority health, and African Americans, Black African Americans were disproportionately affected by a host of health outcomes, and there were very few people in our community that were trained to serve our community. And so, there were, academics and policy people, folks who worked at CDC, the Centers for Disease Control and Prevention, and Atlanta government people, business folks, all came together and had this crazy idea, that we would, that they would start a public health, a graduate public health program at Morehouse School of Medicine. And so this is the first class, and I think about our community meeting today, and Dr. Berger and I were talking about, the numbers of people that would be here in person. It's not the number, it's the spirit. It's the people who come together to exchange and who create community. That's who we are and what we do. And so, I just learned firsthand, the idea of, thinking about who's at the table, who's not at the table, being really intentional about doing something about that, about including, in this case, we were young students learning public health principles to go off and try to do something in our own community, and to do something a little different or more, and those are the, I think, really just foundational principles of the work that we like to accomplish at the Alzheimer's Association. And so as was mentioned, I won't introduce who we are again, but we're a global institution. If you see that sign, I don't know if you've seen it on the bus or a commercial, but it really signifies how on the right side, science, that's a Florence flask, how science really translates into protecting people's brain health, right? And again, just thinking about the work, that we do, the collaboration is, it's not enough from my perspective to publish a paper at a high-impact journal or to have a presentation at a very prestigious scientific conference. Those are great, but it has to translate into how we and what we know to do in protecting public health. And that's why I'm just really excited about the work that we do with the association. As Doris mentioned, we have 74 chapters around the country. That gives us the opportunity, right? Not everything works in the same way in every chapter in every community, but that gives us the opportunity to be physically in community to give resources to people that need them most. And so that's why I came over from the National Institutes of Health. I spent 15 years there, and good government job, you never leave one of those, but the opportunity to be in community and to work with community is something that I certainly take serious and I'm really excited to do. And so with this presentation, I want to talk a little bit about diversity, equity, and inclusion, because what I just mentioned at Morehouse, my time at Morehouse School of Medicine, those are the tenets of DEI. I know you hear this in the news. There are places that you can't even say the word diversity anymore, or can't even utter equity. But I would make the case here today in my few minutes with you that it's fundamental to the work that we have to do at the Alzheimer's Association. So I'll talk a little bit about diversity, what we can do together for inclusion, and then how we're seeking to pursue equity, right? And so no one works alone. That's my team there at the bottom. I'm only here because they give me all of the information and critique everything that I do so that I can come out and represent the Alzheimer's Association. But we've got wonderful staff that are positioned all over the country to help those 74 chapters do the work that they need to do. And so let's just define this, right, how I think that this is fundamental, right? So diversity, I think diversity is just a numerical representation of, what we need to do, who's at the table, who's missing, or also in this case, who's disproportionately affected by Alzheimer's or another dementia, right? So diversity is just taking into account of what's going on, right? And public health, there are three tenets of public health, assessment, assurance, and policy development, right? There's three main tenets of public health. So, diversity and assessment go hand in hand. We're just trying to understand, where the gaps are, what are the opportunities. Inclusion is saying, hey, once we understand where the gaps are, we're going to include invitations to get people to the community forum who we know we can't get there, or risk perspectives that we haven't, really considered. We're going to get those into the way that we work. So diversity and inclusion are just fundamental to the work that any organization might do. And then equity, I think, is really important here. And that's saying when we include, we're not just sending out a blanket invitation and hope that the people who are never here come. We're going to go the extra step to try to understand how to get them here. Equity is, thinking outside of the box to say, maybe, the folks that never come, maybe we need to knock on their door and have a conversation, or maybe the issue is deeper than just an invitation. It may be around trust, right? So diversity, equity, and inclusion. And equity is different than equality. You can't get to equality without considering equity, right? Equity is, I think, so critical and important that we have to do. So I'm not afraid to say these words. Even, if I have to go to Florida and do a presentation, I'll say these words there, because I just think it's fundamental to the work of any organization. Diversity, equity, and inclusion. I'm not scared of it. Well, thinking about diversity, there's a diversity of dementia. I know we're here talking about Alzheimer's, and it represents 60 to 80% of all dementia, but there are other types of dementia that we've got to know about. Lewy body dementia, frontal temporal dementia represent 10 to 25, 10%, the different types of dementia. And there's vascular dementia, right, which I think is really intriguing when you think of disparities over the life course in the way that Doris mentioned. So, vascular dementia characterized by, the quality of the blood that flows to the brain, right? And that's all influenced by cardiovascular health outcomes like, diabetes or, hypertension or stroke, right? And so we know that there are disparities in those outcomes along the life course that don't favor Black and brown communities, right? And so we've got to know the different types of dementia, and then mixed dementia is prevalent. So, this doesn't all sit in a silo. People can have Alzheimer's and vascular dementias, right? So it's important from a diversity perspective just to know the different types of dementia and how they are characterized and how they affect populations that are disproportionately affected by dementia broadly. And dementia is a collection of symptoms related to cognitive decline, memory problems. But diversity is really, really, important there. Dr. Berger mentioned this, 1 in 3 seniors dies with Alzheimer's. More than 6 million Americans are living with Alzheimer's. The take home here is that this is a public health crisis. Caregivers, who I think are just the heroes in this space, who are, just really having to pivot through the pandemic and, searching for resources. Caregivers in this space are doing heroic work. But in 2022, caregivers provided more than 16 billion hours of, unpaid care, and it's valued at $272 billion, right? So communities are linking together to do what we have to do to provide care, but it's costly, and I mentioned COVID during 2020. COVID-19 contributed to a 17% increase in Alzheimer's deaths. So we know that this is a growing public health problem that will only continue to worsen, if we don't link up, right? If communities don't respond in the way that we know that we need to. Resources. Dr. Berger talked about resources. I came from the National Institutes of Health, and in 2011, there was, $448 million, earmarked for Alzheimer's research. Now, $448 million would, change my life forever. I wouldn't have any more bills, and, but at NIH, it pales in comparison to research funding for cancer, like Dr. Berger said, or heart, lung, and blood, right? So, the Alzheimer's Association, through its, AIM, its Alzheimer's Impact Movement, we advocate, so just kind of giving you a background of who we are. We've been able to work with, representatives and other organizations to get that number to $3.1 billion and growing, in 2021. So that means more resources for researchers and Dr. Reinhardt, others, to do work as it pertains to Alzheimer's and other dementia. So, I'm painting the picture that there is opportunity, here, right? There's funding to understand, how diversity, equity, and inclusion are fundamental to this work. This increase in resources has led to, these Alzheimer's disease research centers, which are, all over the country. Really important to be physically in place, just like the Alzheimer's Association chapters, right? So we've got 74 chapters. There are, 30 plus Alzheimer's disease research centers funded by NIH. All of this is, creates this opportunity for partnership, right? This, so I'm giving you the landscape of what's out here and what can be done. Now, just, if you've been following the news, you've heard that there are 2 new FDA-approved treatments that influence the course, the biology of the disease, of Alzheimer's disease. Has anyone heard that? Have you heard that in the news? Right. So there are 2 new treatments. One's called Aduhelm. It was in research, it was called aducanumab. And the other one is called Leqembi, right? And just last week, and this is happening real time, just last week, the FDA convened a review panel, and they found that Leqembi was beneficial from a clinical perspective, right? And so that meant that it slows the cognitive decline. So there are three I'm not going to get too sciencey here, but there are three hallmarks of Alzheimer's disease: amyloid, tau, and then the damage that it causes, and that's neurodegeneration. So the medicines reduce the amyloid in the brain. It keeps the amyloid constant. Now, this is not a cure. This doesn't just completely alleviate Alzheimer's, but what it does is slow the cognitive decline. And its label is for people who have a diagnosis at the mild cognitive impairment stage, right? So it's really important to know that, this progression, and then the other take home is this. Remember this: everyone who develops Alzheimer's or another dementia passes through the mild cognitive impairment phase, right? So if you got a treatment that can keep people, at that mild cognitive impairment phase, then they never will get to, moderate and severe Alzheimer's or another dementia. So tremendous, I think, opportunity for the first time, so linking the funding, the amount of the opportunity to the treatments that are available. Unfortunately, at this point, the Centers for Medicare and Medicaid Services have chosen not to cover this, which means that cost is a barrier for many people in accessing these two treatments, right? And so we advocate for broadly, for CMS to cover these so that people can access them. And every day, every week, people who can't afford these treatments and they continue along this cognitive decline, these treatments become less relevant for their condition. So again, we certainly advocate for these to be covered so that people can have access to these treatments. Well, also, if you've been following the news, in the research news, the Alzheimer's Association published a special report back in 21, and it's on race, ethnicity, and Alzheimer's in America. And this was quite intriguing because this was the first of its kind. 2 nationwide surveys of U.S. adults, nationally representative, and this included Alzheimer's caregivers. And so we included representatives from various racial ethnic populations, and we wanted to understand knowledge of the disease, right? Because think about it, if there's a treatment out there, people need to know what Alzheimer's and dementia is and kind of when is the right time to get it, and if they have any confidence in seeking treatment. So access to care, trust in healthcare, all kinds of questions we asked survey participants to give us some information because we wanted to know what Dr. Berger mentioned. We wanted to know more about what Dr. Berger mentioned and linking in again into the diversity concept. Why are 2/3 of Americans with Alzheimer's are women? Or why are older Black African American 2 times more likely than older whites to have Alzheimer's or another dementia? Or Hispanic Americans 1.5 times, right? We want to understand what are as Doris said, the determinants around why this is important. In my training, we was way back in early 2000s at the University of Michigan. We thought critically about how to categorize these determinants. Some of them are fundamental for everyone, right? So having access to those treatments, fundamental. Having access to health care, any health care that's relevant and fundamental for everyone. But then there are also, maybe some unique determinants based on, people's, experiences in society that we have to account for as well, right? And so, again, so thinking about the diversity, how important diversity is, and then trying to understand what are some of these reasons and why they lead to the determinants, I think is critical and very important. And so I'd have you think a little bit about, what factors are unique that you think that are important for us to consider when we think about why African Americans are 2 times more likely to have Alzheimer's or another dementia. Give that some thought. Well, the good news about the Alzheimer's research enterprise is that we got a bit of a cheat sheet, right? And so the Lancet Commission, a group of very smart researchers who review scientific studies and really take a broad look at research. In 2017, they announced that 35% of global dementia may be preventable. And in my space, the P is a big word, right? So you can reduce risk, but preventable, that's huge, right? Because many times people believe there's nothing they can do to decrease their risk for getting Alzheimer's or dementia, right? And so in highlighting, this 35%, they use the phrase modifiable risk factors. So, Doris and I use the word determinants. What drives this? They say, well, that's a modifiable risk factor. There's some things that if people could modify it, they would reduce their risk, right? And some of those factors were early life education. Now, we can discuss that, but quality of early life education was identified as a modifiable risk factor. Hearing loss, hypertension, obesity, smoking, depression, physical inactivity, social isolation, and diabetes, right? And so a few of those link to what type of dementia? Absolutely, absolutely. So again, it's important to understand, in my opinion, the diversity of dementia, and then thinking about those modifiable, risk factors is so important. And in 2020, they added 3 additional modifiable risk factors, what they highlighted: air pollution, really important to where people live, traumatic brain injury, which I think can link to employment opportunities, things that people are forced to do on a day-to-day, and then excessive alcohol use. And I just think about COVID and the increase of death, Alzheimer's deaths during COVID, and how people really, had to cope with social isolation and maybe turning to alcohol use to sustain, right? And so there are ways to think about this, but they said 35% of global dementia may be preventable. That really gives us an opportunity in public health to try to understand these modifiable risk factors. And so I know some of you are saying, well, some of it's got to be genetic, right? And and there is a known predictor for Alzheimer's risk. ApoE4 is the gene, is a genetic predictor, but that's been determined largely in white European descended populations. And I'll get into why this is critical and important, but the literature, the take home here is, the research is saying more and more that we're trying to understand this disparity where Black African Americans 2 times more likely. It's more not linked to the genetic factors and more linked to other social, environmental, even maybe sociocultural factors that we've got to understand, right? And this is some research that was presented during the Alzheimer's Association's International Research Conference. Great, it's just convening of researchers from all over the world. Really, we're going to meet in Amsterdam in July to have our conference in 2023. But just a great way for us to stimulate the field and to hear research. This was something that was presented in 2020 that added to the growing body of work that's saying that it's not genetic factors that's leading to the disparities that we see. So when we start looking at those modifiable risk factors, really important, right? And so one study, the Sprint Mind study conducted in 2019, was the first to demonstrate that getting blood pressure under control, right? So we're thinking about those modifiable risk factors. Getting blood pressure to 120 systolic, showed a reduction of risk for mild cognitive impairment. Remember, everybody who develops dementia passes through mild cognitive impairment, reduction in dementia, and a combined reduced risk for MCI and dementia, right? So this really kind of doubles down on what the Lancet Commission found. This study showed that getting blood pressure together is so critical and so important. And so cardiovascular health over the life course really shows an opportunity, right, to get to that P. I don't use prevent, but reduce risk for developing Alzheimer's or dementia. And so, the Alzheimer's Association is, really taking this forward with convening the U.S. study to protect brain health through lifestyle intervention to reduce risk. I won't go into the details, but this is really using a community-based approach with recruiting in 5 areas around the country to see what is the recipe of physical activity, how much, what type, or nutrition, what kind of diet here. The literature says a diet, high in fruits and vegetables, low in saturated fat and sugar, really allows for better cardiovascular health, which again could have implications for risk for Alzheimer's and dementia along the life course. But we're recruiting, and we've ended recruitment actually, and had a really nice representative sample. But trying to understand what that recipe is, right? And so that's important. So those 2 were at the individual level, right? Things that people can do, right? Health, we might call those health behaviors. Now, in health disparities, we also know that what people can do is really linked to the resources that they have, right? You might be able to change health behavior in an intervention, again for a publication, but to sustain that over time means that you've got to have the proper support, the resources to be able to afford the fruits and vegetables at Whole Foods and other places that charge so much, for this type of lifestyle change. And so social class is important, or what we call socioeconomic status, right? And so this was some early research that showed that people who were higher social economic status, which is a kind of combined measure of income, how much money you make, education. So as income and education go up, risk for dementia is supposed to go down, right? And then occupation, right? So there's something, this research showed there's something about that composite measure that has a relationship to dementia risk in this particular research study. We found it at the Alzheimer's Association International Conference. I told you we'd get together in 2022. Another researcher showed that cognitive decline, remember we're talking to MCI to dementia, typically seen over 11 years in higher earners occurs faster within just 10 years in lower earners, right? And so, resources matter. So if you want to engage in the physical activity and the healthy diet and all the things that, health behaviors that will protect your cardiovascular health, you've got to have resources to sustain the lifestyle change. It's really important to think of the influence of socioeconomic status on dementia, right? So I'm building out here, how important those two go together. Then there's, I think, we're thinking about the unique experiences of people in this society, right? And so let's just take education out of the SES measure, and let's look at heart disease death rates between 93 and 2001. So this is older data, I'll acknowledge that, but I think relevant. So heart disease and the determinants for heart disease death are similar to the determinants for which type of dementia? Vascular, right, okay, so vascular, staying with the theme, right? And so I think that the risk factors for heart disease death are relevant here, right? And so let's look at the black-white ratio between women and men. And so as we stated, as education increases, the black-white ratio, which is the disparity, should get closer to 1. It should begin to disappear, right? Because you're normalizing, you're standardizing education. But as we see here, that gap widens for both men and women, right? So somebody like me who stayed in school until I was 32 years old, just a whole bunch of education, you would think that, my health would be optimal, or I would at least look like, a white man at the same age as me, right? Because we both have, in my case, PhD from Michigan. What this is saying is that, that ratio is widening as it pertains to heart disease death rates. What might be one of the determinants here? Diet? Maybe, okay. Stress, right, stress, exactly. So, it makes me go back to, I think, when I think about health disparities, research and the theory that drives health disparities research I think comes from sociology. And so here's Dr. W.E.B. Du Bois, graduate of Fisk University, was at HBCU in Tennessee, went on to become the first African American to earn a PhD of any kind from Harvard University. Was in sociology, and his study was around crime in the United States, and just trying to understand the disparity of the time of how people thought of certain populations being more likely to engage in crime, and he pointed to a stress of life for Black African Americans in this society that led to certain behaviors and certain outcomes, right? And I think that stress is relevant for some of the disparities that we see in Alzheimer's and dementia and the unique characteristics of people in this country. So I take us back to that special report, which I think is landmark, race, ethnicity, and Alzheimer's in America. And we found that more than 1/3 of Black Americans and nearly 1/5 of Hispanic and Asian Americans believe that discrimination would be a barrier to receiving Alzheimer's care. So as we begin to put this together, we know who's disproportionately affected. We know there are two FDA-approved treatments that need to be, the label is for people to get it at a certain time, right? And so the people who are disproportionately affected would perceive that they would be treated unfairly because of their race, color, or ethnicity in receiving that care, right? So we've got some real work to do to make sure that people belong and people have confidence in accessing treatment. In that special report also, half of Black Americans report experiencing, so the first one was a perception, half of Black Americans say that they have actually been treated unfair because of their race or ethnicity in the healthcare system. Hear more. Nearly 2/3 of Black Americans believe that medical research is biased against people of color, right? So we're really proud that we advocated and we got that number from $440 million to $3.9 billion. But the people who need us most believe that it won't even get to their community at all, right? So we're working at a certain level of, we're really excited, but the people that we need to serve don't believe that we'll ever get the resources to them. And here, only half of Black Americans in this particular survey, first of its kind though, nationally representative, trust that a future cure for Alzheimer's would be shared equally regardless of race. Now, this was in 2021. It's 23. We've got 2 FDA-approved treatments, and they're not covered by CMS, so the majority of people can't access them because they can't afford them. This survey data was right on because it's not shared equally. There's some people who can afford the treatments today, but the majority of us are not able to access these treatments because we don't have $20,000 kind of laying around for each treatment, right? So another fundamental, I think, determinant. So we said access to healthcare, access to the treatments is really important and fundamental for everyone. I think also fundamental is just being included in the research. So again, we're up to $3.9 billion at the NIH level for Alzheimer's research. Many of these studies, population-based and clinical research studies, don't include the people who are disproportionately affected by the disease, right? So less than 5% of clinical trial participants are non-white. That's a public health and bioethics issue for, I think, all populations. And if you look at the literature, these communities, populations say they're less likely to even be asked to participate, right? And so what's fundamental is just even including a representative population in the research so that we can understand the course of the disease in all people. That's really important. And so the association, some of the work that we're doing is providing some assurance to you that we're trying and doing what we can from a DEI perspective. We drafted and introduced the Equity in Neuroscience and Alzheimer's Clinical Trials Act It was included in the federal budget for this year, and this really provides resources for researchers who are at those Alzheimer's disease research centers that I mentioned to do more with their outreach to underserved communities, more representation among clinical trial staff, because if people feel like they'll be discriminated against, one part of addressing that is to have more people that come from their community that look like them in the clinical trial or in the dementia care system. And then to reduce participation burden. This is when I really like taking the clinical trial or the research study to the community so that people can be a part of that, a part of the study without having to worry about transportation to get all the way over to Midtown or where, to where Columbia University is, for example, to participate in a trial. Bring the trial to the community. That's really important. So as I begin to end, it's a call to action, I think, from a DEI and health disparities research perspective. More multi-level health disparities research, right? So thinking of, moving away from a purely genetic explanation for these disparities, understanding how culture links to behavior. We're saying physical activity is important. We're saying diet is important, but not everybody has the same opportunity to adhere and sustain, particular lifestyle. So what are the resources? And then thinking about the unique circumstances. Structural racism is playing a role in all of this. Interpersonal discrimination in the dementia care system. People are trying to get resources and they're treated unfairly because of their race or ethnicity. We've got work to do in that system. And a part of that is making sure that everyone has a certain level of cultural competence. I might even call it humility. How do our providers, nurses, people, clinical staff relate to disproportionately affected populations so that people feel like they belong in the dementia care system? And then I'll close here with just some examples of what we're doing with those 74 chapters around the country to really link into the equity concept, right? Getting people the resources that they need in a way that they can use them. So we're using participatory engagement with national and local organizations to do just that. Using a community-based participatory research. When we say community-based, that's straightforward. In the community, looking to work with the national organizations that have local chapters all around the country, and sometimes and more times than not, with community-based organizations that are, here in Brooklyn, here that work here specifically. Many of them are outside here today, working with these organizations to get resources to communities that need us most. It's been published in the literature. And I always like to, kind of talk about just briefly the principles of CBPR because, this takes time. We're excited and we know that there's a disparity. We know that discrimination is in play. There are many things that we've got to get going and working on today. But in order to work together, we've got to really think about trust. We've got to present ourselves as the association to be trustworthy. And we've got to go through all the processes that it takes to establish trust so that when we do provide resources, when we come and we say we've got an opportunity for community forums or support for caregivers, that communities and people who need us will believe that we're in it for the right reasons. And sometimes that's reflecting on what went wrong in the past, how we can share power, together, and then how this kind of partnership could benefit our community. That just takes time to get to that place. It just doesn't happen overnight, and that's the real point I want to make. Here's just a listing of all of our national partners. The work is more than logos on a PowerPoint. It's easy to say that we're working together. The hard part is the work, activating the partnerships in the communities with those 74 chapters around the country. I'll say that. But this does assure our communities that we are working with these organizations. National Council of Negro Women, National Black Nurses Association, National Hispanic Medical Association. We work with the Hispanic Nurses Association. I mean, just, National Indian Council on Aging. We're figuring out ways and trying to get to this trust piece, trying to figure out how we can work together where it's mutually beneficial. And that's the work. One of our, I think, most important partners is the African Methodist Episcopal Church. And I tell you, it has taken us 4 years to get to the point where, they trust us enough to give us a listing of their regions and churches all around the country so that we can link our chapters to their churches. We started off with, let's start linking up. And they said, let's talk a little bit more, in another year. Let's put people together. Well, let's talk about what you want to do, And then it's, we got content. We have to review the content to make sure that AME is reflected in the content, right? So before you start passing out pamphlets, we want to make sure that we review the pamphlets and that it's culturally relevant for the people that we serve. And that has taken us 4 years to get to that point. But luckily, we're there. Some of the goals here, but we had a tremendous, what I thought, Purple Sunday, which is a Sunday we have every year, where all of the AME churches are told to do some type of Alzheimer's education and awareness, and then we have a webinar. In the afternoon, a national webinar. We had 8,000 people view that webinar, which was just tremendous. And we had Maxine Waters, who's a representative from Los Angeles, really provide an overview of Alzheimer's and dementia. So just an idea of how partnership gets us to this place of equity. Not just equality, not just saying that we invited people or we're doing something, but we've got to do sometimes something different and more. Here, traumatic brain injury was one of those modifiable risk factors. We work with the NFL Alumni Association every year just before the Super Bowl to have a community event to talk about Alzheimer's among black men, and really it's broadly for the black African-American population. Again, just trying to collaborate and work with organizations so that we could do something different in communities. Here, the Unforgettable play, we partnered with Garrett Davis Production. In grad school, I never thought that I would be the executive producer of a stage play, but again, just thinking outside of the box and how we can engage communities. And this has been a wonderful, test run in communities all over the country to provide what we call edutainment. We're still talking about Alzheimer's being the sixth leading, cause of death, and over 6 million Americans, living with Alzheimer's, and 1 in 3 older adults. That all comes through the script, but it's not me with a PowerPoint or Dr. Berger saying it. It's actors who are, making people laugh, and many times, in this particular play, having people shed a tear because they went through this very caregiving journey, that we see in this stage play, So, again, thinking of something different, and that's not saying that every population needs this, every community needs this, but it has worked in some. And so, as I end, if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, 5.7 million people, and this number is increasing, expected to develop Alzheimer's in 2050 would not, right? And the treatment is not just the drugs that FDA approved. It's the interventions. It's the things that we're doing in community to get people resources and information. It all comes together that if we can get people what they need, this many people, would not develop Alzheimer's in 2050 as expected. And so this makes me think again about the equality and equity concept, right? If 5.7 million is the apples that people are trying to get to, everybody should have an opportunity to be in that number. And sometimes you've got to do something different and more for some populations. That's equity to me. Thinking outside of the box, thinking about partnerships that allow us to do something more and something different. We at the Alzheimer's Association, we're not there yet, right? This is not a championship presentation. We've got our work to do, and that work can only be done by working with national and local organizations to do this in a way where it could be effective. And so that's why we're settling in on equity. I think we've probably done a good job at equality. That means we care about all communities, and all communities get some type of communication from us. But we want to understand how best to serve communities. That's going to take partnership. And that takes time to establish trust. But once we get there, I'm pretty confident that we can do more than what we've been doing. And so equity is achieved when everybody has a chance to be a part of that number, and they're not excluded because of their socioeconomic position, as I mentioned, or their life experiences, or they don't perceive discrimination to be the reason why they can't be included. It's just important that we understand the unique pathways to dementia risk, care, and support. And that's a hard charge, right? Because there's just so many phenomena, things that are happening out in society. But in order to do this well, we've got to try to understand how best to deliver on our mission in ways that are effective for all people. Here's the call to action again. You're really linking into participatory engagement. Just thinking about way back in '95. That crazy idea. I believe in community and partnerships because I've seen it firsthand, and so that's me standing in the back there, back right, hiding, not wanting to be called on in class or anything like that. But just, everyone here went on to obtain a graduate degree in public health. We were the first graduates of an HBCU in a public health program, and we all work in what we call now health equity. When we were in school, they called it minority health, and it went to health disparities, and now it's health equity. It's just the work. The work is getting the resources to people and trying to understand how to do that from an empirical research perspective. And there are probably over 15 or 20 Masters in Public Health programs at HBCUs across the country now, and so this crazy idea, just a few people, together. Just a few people like us in here together. It's the energy, not the number. It's the spirit and not the numbers. And so I firsthand can attest to how important community is, and then inclusion. So this field has been representative from the very beginning. I would make a case as I close my last slide that DEI has been fundamental to Alzheimer's and dementia from the beginning. So this guy on the left, Dr. Lois Alzheimer's, crazy idea. People who were living longer he observed some behavioral changes, and society thought that this was due only to people living longer, older age. And so he had a diverse perspective, and just thinking a crazy idea that there was something else going on. Something in the brain going on, right? And so, to me, that's a nod towards equity, saying not all people are the same. There's something different for some people going on, and he wanted to study the brain. And in doing so, he recruited some of the best scientists, young people, from across the globe to his laboratory in Germany. And this guy in the middle, Dr. Solomon Carter Fuller, had finished an undergraduate degree at Livingstone HBCU College in North Carolina, and went on to be the first African-American graduate of Boston University Medical School. And because of the racial discrimination, people still reporting it in 23, but because of the racial discrimination that he faced, he couldn't pursue a career in research, right? So he was relegated to performing autopsies, But if you're a HBCU graduate like me, whatever you're relegated to, you become really, really good at, because that's what you're taught to do. And he was so good that Dr. Alzheimer's recruited him to his laboratory to work with him to identify what we know now as Alzheimer's pathology. That's inclusion. That's thinking of the different perspectives and equity. Like you're really thinking of challenging what needs to happen in partnership. If you read this, I don't think Dr. Alzheimer's would have gotten to what we know now without Dr. Solomon Carter Fuller, right? And so With that, I'll end, but just this legacy of partnership, I think, should drive all that we do. I think community is fundamental to what we have to go with the Alzheimer's Association, and I certainly thank you for listening and your time today. Thank you.
Thank you, Dr. Hill. Covered a lot in a little bit of time, and there's a lot more information I know that we want to pick at through this, but we will have time for questions during our panel. I do want to highlight that we have 85 people joining us on live stream. So hi, everyone. Thank you for joining. Thank you for taking that time. And I think to put Dr. Hill's comments about community and working in community and a lot of, the points he talked about, stress and everything, into context, I'm very excited to now introduce Dr. Reinhardt. So I met Dr. Reinhardt when I first started at the association in 2019. He's always been such a warm and welcome partner. So just really excited that we were able to do this with you again, because we actually did this in 2019 with Downstate. So Dr. Reinhardt, I'm gonna read all your titles here. Dr. Reinhardt, I'm like, take a deep breath. He serves as the Clinical Advisory Dean, Assistant Professor of Psychiatry, Director of the Geriatric Psychiatry Fellowship Program, Director of the Brooklyn Initiative to Develop Geriatrics Education, or BRIDGE, and the Director of the Center of Excellence for Alzheimer's Disease. Okay? And he's still here. These final two positions were earned as part of an amazing multi-million-dollar grant from the Health Resources and Services Administration Geriatric Workforce Education Program and the New York State Department of Health Center of Excellence for Alzheimer's Disease Program. Dr. Reinhardt is also presently completing a Geriatric Career Advancement Award from HRSA, from HRSA. His career is dedicated to leadership, education, advancement, and clinical care in the fields of geriatrics and geriatric psychiatry, and he has won numerous awards for his educational contributions at SUNY Downstate and contributes actively to the geriatric psychiatry literature. So he will be talking to us today about age and dementia-friendly care across Brooklyn. Please give a warm welcome to Dr. Reinhardt. I clicked the wrong button. This is you, right? Here we go.
So happy Friday, everybody. It's good to see you all. Thank you all for being here. Thank you to everybody who's on live stream and listening in. I'm Mike Reinhardt. I prefer to go by Mike whenever possible. When I list all of the titles, even mentally, I have a small panic attack. And like everything, and like all of us, take everything one item at a time. Having these sorts of sessions today are one of the dreams of the programs that I run. We seek always to engage with our community, to improve healthcare outcomes and rectify disparities. This is one of the major goals of our institution, to seek always to treat the diverse population of Brooklyn in an equitable way and to include all of our populations. And so it's been my absolute pleasure to dedicate my career here in Brooklyn to the care of older adults that sometimes don't always have access to the care that they need. To have equitable healthcare outcomes. So I'm here to talk about some of that, and I hope that this will lend itself to the next conversation that we're going to have as part of a panel discussion where we can further engage you as community members in discussion about how we can do better working with our community to raise the bar for everybody. So I have no conflicts of interest. And I'm happily not talking about treatment today, so no off-label treatment discussions. And as always, I acknowledge the funding that we receive from the various funding agencies that work with us, both the Health Resources Services Administration and the New York State Department of Health, which may be on our live stream today. Hello, Department of Health. If you're listening in, thank you. And I'm going to run through quite a few things, spanning a brief discussion of the epidemiology of aging in general. I'm very grateful for Dr. Hill's excellent discussion of healthcare disparities in Alzheimer's disease. I could not have done that the way that you did. But I will leverage that to talk about why we're doing what we are doing. By talking about our Bridge program, our Center of Excellence for Alzheimer's disease, and talk about how we've done so far and where we might be going next. So for those of you that aren't aware, the global population, the population in the United States, is aging. Each decade that goes by, the number of older adults will be increasing as our population pyramid shifts. And this should be bringing with it shifts in how we think about healthcare, how we think about the delivery of healthcare, and how we train the professionals at our institutions, our colleges of medicine, nursing, schools of health profession, and public health. The distribution of older adults as they age is not equal. There is a large preponderance of older adults that find themselves in 9 states, one of which is our own, New York State, with over currently in 2019, 3.3 million older adults. That number has only grown. As we talked about with Dr. Hill, not only is the distribution of older adults not equal across the United States, but the distribution of resources, of income, of access to healthcare is also not equal or equitable. A majority of older adults find themselves reporting an income less than $50,000 a year, with an enormous percentage of older adults falling under the federal poverty limit. This income disparity is felt disproportionately by individuals of African American and Hispanic ancestry and other communities of color. Locally, the same holds true. Distributions of populations of older adults is not equal across the geographic region. Distributions of income is not the same. Access to healthcare is not the same. So I've included, just for your reference, some materials that show the distribution of older adults in New York City. You could see that on your left. You'll notice in the darker blue colors, downstate colors, I'd like to think, right? Downstate is here for older adults. Higher populations of older adults. And you'll notice in the chart on the right, which is from our one of our funding agencies, actually the Health Resources and Services Administration, using their publicly available MapIt tool, the distribution of medically underserved areas in the New York City region. And you'll notice that there is remarkable overlap between the populations of older adults and the populations of medically underserved persons. Older adults are extraordinarily vulnerable to difficulty with access to care, facing many difficulties accessing care due to changes related to aging, ambulatory difficulties, cognitive decline, etc. And this is the relative distribution of major races across New York City. And what you will notice again is that there is a remarkable overlap, particularly between medically underserved areas and areas which have higher populations of Hispanic, Black, Asian, and multi-ethnic individuals. And again, large proportions of individuals in Brooklyn living at 100% of the federal poverty level. Again, overlap with medically underserved areas. So I talk about this to draw your attention to inequity. And in our division of Geriatric Psychiatry, and in the programs that we run, our Center of Excellence for Alzheimer's Disease, and now more recently in 2019, our Brooklyn initiative to develop geriatrics education, both of which I'll introduce to you in more detail in a second. When we were developing these programs, we thought long and hard about how we would structure those programs to reach all of the populations that needed us the most, not the ones that always can access care easiest. To bring it home, and just to extend some of the data that Dr. Hill talked about, I tried to anticipate you, Dr. Hill, and just bring it home to Brooklyn and New York City. We know that across New York City, across New York State, there's an estimated 410,000 persons suffering from Alzheimer's disease. If you bring it home to New York City, that's about 179,000 older adults here in the New York City region, 55,000 persons in Brooklyn, and about 110,000 Brooklyn family members and caregivers. This is an enormous burden facing our patients, our caregivers, and our healthcare system. I would note that at present, there are 3 centers of excellence for Alzheimer's disease here in New York City, 3 ADRCs, and other specialty centers located around, none of which will be able to entirely touch all of the individuals that need our care. Coupled with this, right, this access to care issue, disparities in distribution of population and income, disparities in healthcare outcome, are a declining population of healthcare professionals that are trained to care for older adults. In 2007, there were 359 total physicians receiving certifying training in geriatrics and medicine and psychiatry. And if you fast forward to 2018, there were only 248 geriatric medicine fellows and 53 geriatric psychiatry fellows entering training, a declining number. The number of professionals in geriatrics that were available to provide care across the United States was around 7,100 geriatric medicine specialists and around 1,600 geriatric psychiatrists. Fast forwarding to 2018, those numbers have only declined. The number of board-certified geriatric psychiatrists in Brooklyn fluctuates year to year between 13 and 14. I like to think that geriatricians have become medical unicorns, something that you are unlikely to see unless you come to an academic medical center, despite the fact that as you age, you're very likely to need our care. All of this is coupled with the aging population and a dramatic increased need for geriatric services. So we, in our division, thought a lot about this, knowing that we can never provide all of the care that our population will need, knowing that the need of our population is growing, and not only is the need growing, but the distribution of access to that care is not equitable. We thought about how best can we solve these problems, and we came up with sort of a 3-pillared approach, a combination of providing care when we can, evidence-based, person-centered, age-friendly care in population centers that need us most, a very strong community engagement and education program, and a heavy emphasis on interprofessional education in geriatrics, knowing that I can't be there for everyone as a geriatric psychiatrist, and my colleagues in geriatric medicine can't be there for everyone. But if I train everyone else, all the other professions, across primary care, across PA students, across occupational therapy students, public health students, et cetera, that my knowledge, my care can be extended through those individuals across various care settings and improve care for everybody. So we've sought programming that helps us do that, starting with things like the Center of Excellence for Alzheimer's Disease. We are now in our 7th year of funding. This is funded through the New York State Department of Health. We're one of 10 centers in New York State and 3 in New York City, providing comprehensive person-centered Alzheimer's disease care and education for all of New York City's residents. And more recently, the Brooklyn initiative to develop geriatrics education, a geriatric workforce enhancement program funded by HRSA. This program is a partnership of all of the colleges and schools and the hospital here at SUNY Downstate Health Sciences University, and some of the major delivery systems here in Brooklyn that are serving our underserved populations, like New York City Health and Hospitals, Kings County, the Brownsville Multi-Service Family Health Center, a federally qualified health center in one of the most underserved areas of Brooklyn, Brownsville, New York. And of course, our Fort Greene Council, a network of senior centers, again, serving a panel of over 13 senior centers that are dedicated to underserved older adults here in Brooklyn, New York. And the goal of that program is to permanently and sustainably transform the healthcare workforce and community in Brooklyn to be age and dementia friendly. So, this is maybe out of order. So to start, thinking along the lines of Dr. Hill, when building the teams to create these programs, we wanted to make sure that our teams represented the community, right? That represented the older adults that we would be treating. We made sure that we hired individuals with language abilities, cultural affinities, backgrounds that represented our community. Spanish-speaking staff, Mandarin and Cantonese-speaking staff, Vietnamese-speaking staff, Urdu, Hindi, Creole. Everyone that we can bring on board that represented our community was brought on board to serve. And that includes both our Center of Excellence for Alzheimer's Disease team and our Bridge team, a diverse team of individuals across diverse professions: nursing, occupational therapy, School of Health, public health, social work, medical anthropology, etc. And of course, medicine, geriatric medicine, and geriatric psychiatry. And then we took a look at the population, where we knew we were most needed, and that's where we centered our work. We have centers of excellence for Alzheimer's disease here at SUNY Downstate, and again at a major focus of older adults and a major focus of need for Alzheimer's disease and related care at Coney Island Hospital. We have growing work with our partner at Kings County Hospital, and again, the Brownsville Multi-Service Family Health Center, and have outreach work happening not only across all of the boroughs, but again are working to develop enhanced partnerships with federally qualified health centers across the boroughs in major areas of need. Sorry that I got out of order there. And a major focus of how we are outreaching all of these different communities, all these different healthcare provider healthcare systems, is the new, relatively new initiative by the Institute for Healthcare Improvement and the John A. Hartford Foundation, the Age Friendly Health Systems Initiative, which is centered on the 4Ms framework, making sure that all providers and all community members understand the importance of communicating what matters to patients, providing person-centered care, medication management, knowing what high-risk medications are, how to communicate with your provider about polypharmacy, the risks of taking multiple medications and high-risk medications, and of course, mentation, Alzheimer's disease and related dementias, depression and delirium across healthcare settings, and the ever-important mobility, for without mobility, how can we engage in what matters to us? So SEED and the Alzheimer's Disease Center, Center of Excellence for Alzheimer's Disease, and the Bridge program have 7 pillars of our programming. And I could spend most of today talking to you about these pillars. I'm going to highlight them. Spanning from our interprofessional clinical education and clinical care programming at the Alzheimer's Center, in which we provide education on high-quality Alzheimer's care to all professions at SUNY Downstate Health Sciences University, while simultaneously providing care to communities in high need for our services. We've developed an advanced certificate in public health geriatrics, which is available to all of Brooklyn and beyond, and proving the knowledge base in geriatrics, public health geriatrics for all professions. We've developed an ECHO program, Extension for Community Healthcare Outcomes, in which primary care providers and all trainees are invited to present cases and review the evidence-based treatment of older adults, echoing the knowledge of geriatricians out from the available specialists at Downstate to the community. We've developed a micro-credential in our School of Health Professions to make sure that all of the health professions, spanning from midwifery through physician assistant students, have specialized knowledge in geriatrics. And of course, my favorite thing, community engagement and education. We have enhanced partnerships with the Fort Greene Council, in which we've developed, through community-based participatory research approach, an understanding of the needs of the community and provide an ongoing curriculum throughout their senior center partners on all topics in geriatrics. We have a primary care education program, particularly focused on our partners at the New York City Health and Hospitals, Kings County, and the Brownsville Multi-Service Family Health Center, in which we engage with all of our partners in implementing age-friendly healthcare practices. And that includes on-site preceptorship and age-friendly care, particularly at our partner Brownsville Multi-Service Family Health Center. I'll talk about some of the outcomes in just a second. So we've had some successes. Our Alzheimer's Center has reached level 2 age-friendly designation, and our University Hospital Downstate has reached level 1 age-friendly designation, as has our partner New York City Health and Hospitals, Kings County, and Brownsville Multi-Service Family Health Center. Our providers and our patients love these initiatives. I want to bring this home and talk about what this means for patients and their families as we teach them about age-friendly care. Our patients love when we ask what matters to them. These are quotes directly from patients where they've talked about how they feel. I'm just going to read a selection. The first time my doc asked me what matters to me, I froze. No one had ever asked me what matters to me, and I froze. Then I thought, wait, why had no one ever asked me what matters to me? Thank you for doing that. And we hear this on and on across patients in Alzheimer's care settings or in regular ambulatory care settings. Engagements with age-friendly care are meaningful for patients and help them engage with their provider. And our providers love it too. In many cases, they've reported that it helps them combat burnout due to stress. Their connections to patients improves as their care quality improves. The shift of my practice to start appointments by discussing what matters to patients has helped me remember what matters most to me, people. Yes, they're patients, but most importantly, they're people. This has helped me push through difficulties of practice this past year. COVID was tough on our providers, and engaging with patients helped them feel connected back to their work. We've reached, in 2020 to 2021, over 1,200 individuals in our community outreach sessions for the Bridge program. And that number only grew as we went into 2021 and 2022 with almost 2,000 individuals reached by our community outreach education program, which focused on all topics in geriatrics and particular focus on age-friendly healthcare. Our Center of Excellence for Alzheimer's Disease focused its work on underserved populations with approximately 1,200 folks reached on various topics in Alzheimer's disease and related dementias in the 2021 to 2022 year. Not only did we reach a large number of people, but we're starting to see positive outcomes in the work that we're doing in the community. The majority of respondents that we reached were people that needed to be reached. They were female, they were Black, African Americans in their 60s and 70s. And almost all participants found that our sessions were excellent or good. They learned a lot from us. They learned the importance of having a geriatric provider, the importance of having annual exams and staying healthy, engaging in preventive management to reduce the risk of negative cognitive and physical health outcomes, learning the difference between mental health and depression and what to do about it, improving knowledge about dementia and Alzheimer's disease, and of course falls and how to prevent them, understanding medications, polypharmacy, and what is important to patients with their providers, learning about safety and efficacy of vaccines, particularly related to COVID, and of course, learning about the joys of life, the benefits of sex, enjoying sex and intimacy, even as an older adult. We've reached an enormous number of interprofessional trainees through this program, over 1,200 up until July of 2022. In our age-friendly seminar series, we've reached almost 5,000 individuals covering topics across the interprofessional geriatric spectrum. And our ECHO program, focused on primary care, education in geriatrics and clinical care, has reached almost 1,000 individuals as of the start of this academic year. And not only have we, again, reached large number of trainees, but the outcomes from those trainees are very positive. We survey individuals that come through our programming to understand how we're doing in lifting the bar, improving equity in care, in age-friendly care for older adults in the populations we serve. Our students, our trainees, our primary care doctors strongly agree that they're able to describe the components of evidence-based, age-friendly care as it applies to their role in the healthcare delivery for older adults. They're able to identify the interprofessional roles and responsibilities of the interprofessional geriatric team to provide age-friendly, high-quality care for older adults. And they're able to describe the impacts of social determinants of health, culture, equity, and discrimination and bias on the health and wellness of older adults. Multi-pronged approach, trying to raise the bar across all trainees, all community members, to bring us all back together and engage in the best care for everyone. So not only are learner outcomes improving, not only are we reaching large numbers of individuals, but also our care outcomes are improving. And I'll talk a bit about particularly our Center of Excellence of Alzheimer's Disease, where I have the best access to data. We've gotten better at fall risk screening, almost a doubling in the individuals that are screened for fall risk. Our advanced care planning has improved. Our ability to de-prescribe high-risk medication prescriptions for older adults has improved. Where at baseline, almost 86% of older adults that were coming to our service were receiving at least one high-risk medication. We took this on ourselves as a matter of, as a mission. Regardless of who was the prescriber for that medication, we did the outreach, we did the coordination of care, and we made sure that we de-prescribed each and every high-risk medication in as many older adults as we could hit. And that number went down from 86% to 50% over a 2-year period. Really, really proud of this, improving our care outcomes for older adults. One of our partners improved their fall risk screening over 8-fold in just one funding year. The rates of opioid screening risk in the same partner increased to 100%. And we have more to come. We're out there, we're doing work, and we're improving care outcomes across learner groups and across community members. If there's anyone listening to this that needs Alzheimer's and related dementia care, we are here to you. Downstate is family, our patients are family. Reach out to us and we're here to help you provide care. We will do it confidentially, and we will do it in an evidence-based way. Thank you.
So the comments in the chat say thank you, Dr. Hill, thank you, Dr. Reinhardt, excellent presentations. We will work to get copies of the presentations, PDFs, to everyone here. And we hope you've been taking notes, because we're going to move into our next part, which is our panel. For those who are online, we will be monitoring the chat. If you have something there that we can bring up, we will definitely try to capture that. But we have a few questions here, and we encourage you, if you have questions from earlier today, this is the time to ask. So, Dr. Reinhardt.
So, good to see you all again. We wanted, when we put together today's symposium, we wanted to make sure to include a panel discussion. We learned in 2019 during our last symposium that the panel discussion was the highlight. Engaging with the community, discussing the issues, and thinking about solutions as a group was really valuable. So it's a pleasure to moderate this panel today, talking about Alzheimer's disease and related dementias in communities of color, and working to equitably distribute care and improve care outcomes in our community. I'm just going to briefly introduce some of our panelists and allow them to come to the podium if they'd like to discuss their work, or remain seated, whatever we're most comfortable with. And I will start from the left. So it's my pleasure to welcome Claudette Macy, MSW and LCSW, who is CEO and Executive Director of the Fort Greene Council, one of our partners in the Brooklyn Initiative to Develop Geriatrics Education, and an outstanding network of Brooklyn's finest senior centers.
Good morning, everyone. My name is Claudette Macy, as Dr. Reinhardt said. And Fort Greene Council, Inc., it's a Brooklyn-based nonprofit organization. And we have our motto, we used to say, and we still say, from the cradle to the grave. We serve children 2 years, and we serve older adults from 60 to infinity. So we have more, right now we only have one Board of Ed program, so we're mainly involved with older adults 60 and over in 14 of our programs. And we've been working with several Alzheimer's Association of New York chapter. We've worked with the Memory Tree. We work with a lot of older adults in the field, especially not only do we do health and wellness, which includes mental illness. Alzheimer's is a big part of that. We do recreation education activities, and you do not have to be sick. We're not a daycare center. We're older adult club, which is the new word. Department for the Aging has changed, and we're marketing ageism. We want to stop it, so we don't use the word old people. They're older adults, so we say OACs, which is our older adult clubs. And I'm happy to be here today because this program with Dr. Reinhardt and Downstate has been great, great, great and helpful to us. I'll say more, but the program started before COVID, just before COVID began, and I want everyone to know online, it never stopped. With the theme under Dr. Reinhardt leadership, we were on the Zoom platform, and sometimes we'll have 100 people on Zoom. That's when it was really bad. Then as they start coming into the centers, we have some of the centers, we do hybrids. And so it's very, very educational. And whoever's listening, I'm making my plea on behalf of Fort Greene Council and all the older adults in Brooklyn that this program continue. And if you, as you ask questions, you'll find out why I'm saying that. So thank you again.
Thank you, Ms. Macy, and thank you for being here. It's my pleasure also to welcome Dr. David Stevens and Dr. Melissa Lee. Dr. David Stevens is Chief Medical Officer of the Accountable Care Organization at New York City Health and Hospitals, and also Chief of Ambulatory Care at NYC Health and Hospitals, Kings County. Dr. Stevens?
Hi. Good morning still. Hi, that's my email up there. I hope I get nothing embarrassing while I'm talking. I'll just give a couple of introductory comments, and then I'll run you through a couple of slides. My role, I'm a primary care doctor at Kings County across the street in this community. And I also lead the Accountable Care Organization, which for all of health and hospitals, which in a nutshell strives to reach the triple aim for older patients. That's an oversimplification, but not too much. Our fundamental approach is a primary care system that yes, we don't have enough geriatricians, but we also don't have enough endocrinologists, and we don't have enough psychiatrists. But primary care is really the science and the enterprise of taking care of what do our patients have. As the diabetes numbers grow, we had to become proficient in diabetes. As depression became more recognized as a prevalent condition throughout all communities, the primary care enterprise had to become proficient in detecting and managing depression. And that's where we are with Alzheimer's and dementia. We're not there yet, but that's the charge we have to take, because that is what our patients have. And we look to Dr. Reinhardt and his incredible team to help give us some guidance about what the best way to approach this is. But it is important at the end of the day that the primary care system be able to detect cognitive impairment and be able to address it. I'm going to give you a few slides. Thank you. All right, so that's louder. So that's me. So the challenge, again, at the ACO, again, looking at a triple aim, how do we keep our patients healthy? How do we avoid hospitalization, nursing home admissions whenever possible? There's a cost benefit to doing that, but there's also just a quality of life. Our patients don't want to be in the hospital. They don't want to be in a nursing home. How do we start to pick these risks like dementia up early? In our system of H&H, we have 143,000 primary care patients that are 65 and up. We're learning a lot about the epidemiology as we do this, and it turns out it's really probably at 75 that we have to start worrying, but it's a big number. We deliver care across 11 hospital-based practices and over 60 community-based practices. Kings County is one of the largest of our practices and is at the forefront of this work, as Dr. Lee will get to in a little bit. But where we started, there was no routine screening across our system in primary care. That's true of most primary care practices. That wasn't a gap for us. It was a gap for all of primary care. We have less than about 10 full-time equivalent of geriatricians across our system, and we're not worried about that. We can't fix that because the numbers of geriatricians are going down, but our primary care numbers are going up, and that's the enterprise, that's the army for taking care of this challenge. Again, minimal numbers of neuropsych, geriatric psychiatrists. Our patients, about 21% of our patients are uninsured, 10% Medicaid, and then again, looking at the 65 plus, the slight majority is Medicare, but we are mindful that 21% of our patients have no insurance at all. So here's our plan. First of all, we had to implement screening, and how are we going to do that? And we decided to do this as part of an annual wellness visit where we would screen for dementia, but also screen for fall risk, also screen for hearing loss, screen for losses of ability to take care of yourself, as sort of a comprehensive wellness visit as part of routine primary care. How are we going to do the dementia screening? Specifically, we selected the photographic memory impairment screen, PMIS. I'll show you that, and I'll talk about why we did that. And we screened using our nursing staff. Our PCPs have 1,000 things they're juggling, and the more we could do things as a team, the more consistent we'll do it, the more reliably we'll do it, and the more we'll be able to scale it up. If we just keep lumping things on the backs of the PCPs, it's just not going to happen. And then how do we manage it? And we put about a year into developing guidelines that primary care could follow for the assessment and the management. This is the PMIS, the picture group based. This is how we screen. This is something we show the patients. We ask them to remember the 4 pictures you're seeing, give them a little bit of time, and then we ask them to recall those 4 pictures, those 4 images. And if they can't remember one, we have a scripted hint. If you can't remember airplane, we say, well, it was a mode of transportation, and then patients get half credit for that. And it's incredibly efficient. It goes quickly. It's easy to train. The staff like it. It doesn't feel like they're reading off a questionnaire, and it works in all languages. We haven't formally had to get it officially interpreted into the 160 languages because it's pictures. We are indebted to the group up in the Bronx, led by Dr. Verghese, for developing this, and we're really happy to be using this. This is our guidelines, and forget that thing on that side, unless your eyes are really, really good. Forget about reading that. But that's our guidelines. We squeezed it onto one page. But on the right side, this is the essence of our guidelines. And if you screen positive, and your depression screen is negative because we see more depression than dementia, and those two blur in terms of symptoms. And you have an impact on your ADLs, your ability to take care of yourself related to your cognitive impairment. That's probable dementia. And in this guideline, we advise what's the right blood test, get a CAT scan, some comorbidities to rule out, and consider medications. The anticipatory guidance, explaining to the patient, to the family, how to stay safe, what to expect. Without a doubt, that's where the value of this is. The medications are disappointingly low in their effectiveness, but keeping patients safe and active and in their home and out of a nursing home if that's what they want, that's really it's the anticipatory guidance. And we've standardized that and built that into our medical record. And we only refer to the specialist if there's atypical symptoms, and most patients are typical. That's why they're called typical. If it's a typical Alzheimer's presentation, a multi-infarct dementia presentation, keep them in primary care. That's where our patients want to be. They don't want to be bouncing around to different doctors. They trust their primary care, and they want to stay there. If they've got some cognitive impairment, but their ADLs are intact, they're taking care of themselves fully, we can consider that a cognitive impairment, and we just keep watching them. So what have we learned? What worked? Again, the PMIS is a great screening instrument. We've been really happy, and IHI does accept it as a valid screening instrument. Making the guidelines friendly to what PCPs can do has been really important. Challenges, again, we were putting a lot of energy into screening people 65 to 74. Probably not a lot of value in those in a general population, and so we're really focusing our initial efforts on 75 and up. Technical, how do we schedule these annual wellness visits? We're on track. We've implemented at 4 primary care practices, including King's and Queen's hospitals, which are 2 of our biggest. But it's a lot of kind of technical behind-the-scenes work to schedule these. PCPs are reluctant because the medications are, when do I use these medications? How do I follow them? And really kind of focusing on that's not the most important part of this. That doesn't lead to safer home care, that doesn't, in the majority of patients, it doesn't keep them out of the hospital. But keeping them in primary care, understanding how this their cognitive impairment affects their overall health, that's what primary care can do. And that's it for me. Thank you. I'm going to close my email out if that's okay with you.
Thank you for that, and thank you for your work that's touching an enormous population across the entirety of New York City. It's a pleasure also to welcome Dr. Melissa Lee, Director of the Primary Care Residency Program at New York City Health and Hospitals, Kings County. Yeah.
This is on.
Awesome. My most comfortable place is not on a stage, so apologies. All right, so my name is Melissa. I am a med-peds doctor at Kings County, and I also run our primary care internal medicine residency program. And I've had the pleasure of working with Mike and his team for a number of years as part of the GWEP program. And so I just wanted to add on from what David talked about in terms of, David kind of outlined how we're doing things. And I guess I see myself as one of the implementation people. We come up with some ideas and then we test them out, and that's usually where my wheelhouse. So our team was able to work with the IHI this year. They had a group of folks from across the country who came together to talk about how practices screen and care for patients with cognitive impairment. From the initial, somebody walks in the door, are we doing screens? Like David talked about the PMIS. How do you make a diagnosis? And then how do you help a patient and their caregivers? And I just wanted to share some results. When we embarked upon this work, we weren't exactly sure where to start. And what we often do, which is we asked our patients, we asked our caregivers, and we asked our primary caregivers to see where the needs were. And so it was very interesting. We started with our primary care providers and we asked them what kinds of socialization or support resources would be most helpful for their patients. So does anybody, I don't know if there are any docs in this room or folks who practice primary care, what do you think the most common thing was that folks said their patients might need? Connection. So tell me more about that, like a social connection or? Yes.
They're communicating, like their brain is active, they're doing things. Here, I feel like from what I've seen here, they're more isolated, and then they go into, like that stage of like being isolated, and now their brain is not that active, like they're not learning, they're not talking, they're not doing a lot of things, and yeah.
Absolutely. So I love that. That was such a patient-centered response. So thank you. That's what our patients said. So our patients were most interested in learning about senior centers. They were interested in learning about community activities. They wanted to engage with others. As doctors, so I have to tell you, we didn't say the same thing. Like 90% of us said home health aides. Our patients need home health aides. So we had this really different perspective about what our 60 to infinity patient population might need. And caregivers were somewhere in between. About 50% said that their family members needed help at home. So that was the first thing that we thought was really interesting. Only 23% of our seniors said we need more help at home. So another thing that we asked about is a number of different screening questions for social determinants of health, and this is something else that we've been doing regularly just recently, which is, I think, really exciting. And we would always ask some questions, but how do we ask them in a regular manner to all of our patients with visits? And so we asked about food insecurity and patients versus caregivers in terms of perception. So how many of our patients at Kings County do you think, like just wild stab, said that they needed some help getting food at home? 50%, 75%, 25? 80%. 80%? Okay, I got an 80. Have any others? 30. I got a 30. All right, so let's, any other guesses? 25. All right. So we had about 47% of our patients say that they were worried about having enough food to eat. And so their caregivers, would you think that that number would go up or down? Up or down? So I got a down. I heard an up. Somewhere in between? Up. So interestingly, caregivers, 14% of caregivers. So people who are taking care of older adults felt like they were making sure that their families had food to eat, but those older adults themselves were worried about having enough food to eat. And I thought that that was really telling and really provides a lot of opportunity to try to explore more. Another question that we asked was about, are you able to connect to all the care you need to manage your health care needs? And so in this case, our patients said 25% said that they didn't have enough resources. Their caregivers, 62%, thought that they didn't have enough resources. So again, really different perceptions depending on who you're asking questions to. And that's what really, I think, opened a lot of doors for us. We had different ideas like, oh, we need to go to universal screening. We need to ask everybody these questions. But then what do we do when somebody screens positive? And who should be in the room when we have those conversations? I think what this shows us is when somebody comes in the door alone, and I'm worried that there may be something going on with their memory, that having that conversation as just a dyad is probably not enough. And I should really be asking more questions about who's involved in the patient's life, who's taking care of them, what sorts of social activities are they connected to, and how do I try to attack this from a perspective that medications are not going to be the answer. And how do we really look at that patient and their family more holistically and get the different conversations? I'd say that Zoom has gotten, or Doximity has made it much easier for us to get caregivers, because so many times someone says, my daughter's at work, or my son is busy, he can't come right now, but being able to get somebody on the phone so easily and do a conference call is actually pretty amazing. And so we've used that quite a bit. The other thing that I will give a shout out to at Kings County is a couple of years ago, we were gifted with this amazing group of folks who have been trained to be community health workers. And so we've realized that the answer is not necessarily just in that office with one-on-one with a patient. It's really using the resources we have and connecting to folks who know what their community resources are. I'd love to say we could take care of things within our walls, but we can't. It's 20 minutes in my office. And really being able to connect patients and families to caregiver resources, to senior centers, to things that our patients want to engage in is probably the best thing that we can do for them. Thanks.
Yeah. So thank you for that, and thank you for working on the modifiable risk factors that contribute to cognitive decline in populations that really, really need that help. So next, individual needs no introduction. So Dr. Carl Hill, Chief Equity Officer of the Alzheimer's Association. We've had the opportunity to hear him speak. Did you have any? Okay. And last but very much not least, Dr. Wrights, Associate Professor of Neurology and Epidemiology, the Gertrude H. Sergievsky Center and the Taub Institute for Research on Alzheimer's Disease and the Aging Brain at Columbia University as her home, and a prominent researcher in the field. We're fortunate to have her. Thank you.
Oops, can you hear me? Yes, okay. Good morning, everyone. First of all, I really wanted to thank Dr. Reinhardt and Dr. Berger from SUNY, Downstate, and also the Alzheimer's Association, and Doris. We've been working for many years together for the invitation to join this panel today and talk with you about this very important topic that's really close to my heart. So I'm Associate Director of the Taub Institute at Columbia University, and I'm leading also the genetics core of the ADRC, the Alzheimer's Disease Research Center at Columbia University. And my work is really, threefold. I started working on Alzheimer's disease about 17 years ago, and, I think probably very similar to many of my fellow panel members and, speakers that really had at the beginning really like a personal cause, because my grandfather, who was a chemist, was always like a very smart man and a brilliant mind, up to when he was 78, really at the age of 78, really started to decline really fast, and was really horrible to see, up to the point that he wouldn't recognize his grandchildren anymore. And so that was really something that originally really got me interested in Alzheimer's disease, specifically when I was in medical school at that time. And then when I started my work at Columbia, it really became, I'm originally from Germany. What I really didn't know at that point is really how tremendous the health disparities really are here. And when I started working at Columbia and that became clear to me, I thought that's really something where I should dedicate my career to help alleviate this gap a little bit as much as I can. So my work is really threefold pretty much at Columbia. So we are working similar to really what my fellow members said. We're working with communities of colors to really try to empower them, educate them about brain health, talk with them about the risk factors they really should watch out for, and they can really modify themselves. And connect them with, connect the caregivers with the resources that are out there, but they often don't know about where they can get help, and where they can also, join caregiver groups to really talk about the issues they are experiencing in everyday life. and also talk with them, but also talk with them about how important it is to, be part of the research and stand up for your community, because, and how important it is to do studies also specifically in communities of colors for scientific reasons. And the second part of my work is, that we try to work with our younger community members. We go to the schools, we work with middle schoolers and high schoolers to increase the diversity in the workforce and try to get them, into this field, so that we really have culturally, that we really increase and we heard about the importance of that earlier today, that we really increase the diversity in our workforce, which is a big barrier for many patients and also caregivers, right? And try to really show middle and high schoolers already, what they can do and how they can contribute and where they actually can go. And that's something I really cherish, because we have done this for many years and now we really see how that flourishes, and we stay in contact with them and see them as PhDs and MDs, as people who really work in the field, and that's so wonderful to see. And in terms of really the research I'm doing, I'm focusing mostly on genetic research. So my lab is trying to identify the genes that cause Alzheimer's disease, specifically in African American communities. The reason that we're specifically looking at genes and why I really was specifically interested in genetics is that genetics is just very close to the cause of the problem. And once you know the gene, it gives you a very direct pathway to understanding what's actually going wrong and why. And that's why it's such a powerful tool and part of the science to understand what's going wrong in Alzheimer's disease. And one of the main projects, just to let you know what actually the biggest part of my work is right now, as we speak. That's a very new major project we are doing, which focuses on exactly that and trying to find the genes and the causes of Alzheimer's disease in individuals of African ancestry. And that's a large nationwide project where we recruit and assess about 15,000 people, African Americans, but also about 6,000 people from 10 African countries, to try to identify the genes that cause the disease in individuals of African ancestry.
Thank you. And thank you as well for that work. Very important work. So it's our pleasure to open up the panel. And so I'm going to try to alternate between questions that we've formulated for the panel and also asking for questions from the audience to make sure that we engage everyone. So I'll start off with one question, and then we'll see whether the audience is ready to engage too. So how can healthcare providers and organizations collaborate with community-based organizations and stakeholders to develop comprehensive, culturally appropriate approaches to Alzheimer's disease care in communities of color? Yeah.
Okay. Hello? Can you hear me? Okay. So, as the head of a community organization, we call them CBOs, and I just wanted to say we've been doing this for 50 years. This is our 50th anniversary. Okay, so how the CBOs can be very helpful is a number of ways. Everyone 60 and over, and that's the guideline by New York City Department for the Aging, you must be 60. Places like Downstate, Kings County, etc. If you get to the, as you call them, senior center, they're now called older adult centers. Linkage between CBOs that are dealing with older adults and doctors, anybody who is medically and helping with Alzheimer's. If you link, the reason linkage is good, because in the community of color, and I'm speaking from knowledge that caregivers, they're going to work in the community of color. Sometimes most of us don't have the ways and the money to hire somebody, or sometimes the services, that's the first thing, doesn't exist in their community, or they don't know how to navigate. So looking for some place for your older ones, your mom, your dad, whoever, to come during the day to stay while you go to work, you feel safe. If you find an adult daycare, that's your Medicare, Medicaid billing program. And a lot of times, there's been a lot of stuff, I'm not talking about that, but the older adult club, it's free, it's funded by New York City Department for the Aging, and they can come free. We don't charge for the meals. They'll get breakfast, they'll get lunch, and they'll get all the activities to keep them engaged, to stimulate their brain. And that's the way I think it's wonderful. I can talk about one thing because I know we're running out of time. About 10 years or 15 years ago, this is one incident, but there's several. Someone called one of our older adult club, at that time senior center, and the young lady was saying, my dad, I don't know what to do with him, and I've been looking all around trying to get him tested for Alzheimer's. I think he's going crazy and all that stuff. And somebody put me on the phone and I asked I'm a social worker. So I asked, what changes, how did this come about? And then she said to me, my mom just died, they were married for 60 years. Of course, I know right away that's a trigger, and it doesn't really have dementia or Alzheimer's. So I asked her to bring her father to the center, and she brought him one day. She said, I never heard of this, blah, blah. And every day she said he would cry. The first day he came, of course, he was sitting there crying and carrying on, and she asked us to keep an eye on him so he don't run away and all this stuff. And the fact of the matter is, he did not have Alzheimer's, he did not have dementia. He experienced a loss. After 50 years, what happens, as most of you know, everybody can figure out, sometimes people marry for a long time, and what happened? Their loved one die after 60 years, and they live within 12 months, they're gone. It's a great loss and other medical and psychological stuff. And in the end of that, within, I think one of the directors here, that was her center, about 3 months in, or 3 weeks, the daughter came and said she wanted to make a donation to the older adult center. And I said, why? She said, I don't know what happened. He comes home and he gets up early in the morning. He wants to go to the center to see his ladies. So, and he said all the ladies love him. And so the doctor, she had taken him first. Let's say we have to test him for dementia and Alzheimer's. She took him back, and they said, there's nothing wrong with your father. He was just grieving. So that's one thing. And then we have other people coming into the centers, and our workers, and I try to do a lot of training to tell the directors and all the staff, if you see something different, then let us know. And we have helped a lot of people, and we refer to Downstate, to the program, that we can see they're home and they're busy and nothing is wrong just because of their cultural differences. Because community of color, most of you know, and America is the melting pot, and Brooklyn is a big melting pot. We're here from immigrant parents, we're here from everywhere. Our culture is very different. And what I feel, Dr. Hill, that I have a lot of thoughts on to get this, I heard what you were saying this morning, part of it is to include somehow Black people in the studies that they're doing for Alzheimer's. We're not in there. They don't know about us. What I do is have culturally sensitive staff, and we know if you're coming in every day and you're looking fine, and today you don't look like your hair comb or you're smelling or whatever. We have the staff that would say, are you okay, and talk to you, and then said, okay, we go in the file, we ask permission, can I talk to your daughter or whoever is in there, and we call, do you notice this with your mom? I can tell you many stories. The last one I'm going to say, there was a member that was driving fine, doing everything, great, sharp, living this community. And one day she came and she said, when she was leaving, somebody stole my car keys. Nobody steals in the center, like someone of them told us somebody stole their coat. So those were signs that we look for. When we found out, thank God, she never knocked anybody down before we caught it. If she wasn't coming there, her son that she lived with never knew anything. He goes to work, he come back. Unfortunately, for some reason, men that are caregivers don't look into the little fine things, not to be saying women. But you know, women, female, they're more nurturing, they have money. They may know looking to something, not to say men don't. But we've had a lot of experience where when they live with their son alone and he's young and he's working, and so that particular person, I don't know if you have stages in dementia, Dr. Reinhardt, so I guess that was stage 4. But when we called the person in and they were in denial then, and saying, no, nothing's wrong with her, and she lived downstairs by herself. And when we recommend taking her someplace, you know, to get diagnosed and stuff, it was like the end stage, and we were able to get her services because of what? Culture. In the black culture, regardless where you come from, if you come from down south, it's a taboo to say somebody, and the gentleman name that's Alzheimer, I wish they'd name it something else. They call it old-timers. The people say, well, I said it's not old-timers. And in the black community, oh, you just have old-timers because when he gets old, it's supposed to happen. So, and they don't know it's a brain thing and whatever. And so it's I'm all advocate, and a lot of work needs to be done. I can't help everybody, but I'll start in the Brooklyn community where I live to really educate. We need a lot of education to our community of color. We don't have the services. And then we're saying, you know, if something is going on, don't go for therapy. It's something like that because you're black. So what do? We need a lot of people like ourselves who know of culture, like somebody from Germany, your culture might be different, you for some way. So we need a lot. So the older adult clubs, as you will call senior centers, look in Department for the Aging website, they're all over, they're 500 of something, all over the city, all the 5 boroughs, and just contact one of those clubs, and you have them where they're old, and that will help. We look at the older adults as they come in, and so that's how I think CBOs are very, very important.
I think so.
Especially senior centers.
So you're, for me, the most valuable resource in the community.
Thank you.
You help maintain my patients in the community, and you're vital partners when we share individuals. So it sounds like there's lots of opportunity for education across multiple vantage points, both for your clients, for the seniors that enroll in your centers, for your staff to make sure that we understand the signs and symptoms, and also to discuss research. Were there any other comments from the panel? Questions? Oh, hey. The microphone is coming.
Hi, good morning, everyone, or afternoon, not sure what it is. But thank you so much for all of the presentations. They've been illuminating. I wanted to,
So if you could, just hold it a little closer.
Okay.
There you go.
You know, I will let you know that I'm a mental health provider myself, and I'm a certified rehab counselor, and I worked in Kings County for many years I worked with addictions, people who were addicted to substances. So, you know, I hear you talking a lot about screenings and education and research and creating awareness. But I wonder, what are you doing to impact people's behavior? Because all of that does not necessarily change behavior. And one of the things that I feel that we are not doing enough about is I think blood pressure and the medicines that we give people, and also the fact that blood pressure just goes, people don't have, you don't get your blood pressure checked unless you go to the doctor. I think that should stop. I think we need to give people blood pressure machines. I think we need to really impact behavior and get people's blood pressures. Really to help people take responsibility for both the blood pressure and their blood sugar. So anyway, that's what I have to say.
So I'm happy that our primary care colleagues are here. If anyone wanted to discuss some of the pathways that we take towards motivational approaches to health behavior change, is that the question?
So specifically about the questions about high blood pressure, was that? Or just general behavior, improving behaviors?
Help. There's a word that was used earlier. How do we help people change behaviors that will impact their health on an individual and community level basis?
It's just about the hardest thing that we can do is support people changing what they do every day, changing what they eat, taking medicines, starting to take care of themselves in different ways. I think it is the hardest. We do train our residents and our attending physicians in a skill set called motivational interviewing that helps them support the patient's own drive towards and own reasons for changing. I can't tell you the last time anybody changed their behaviors because I told them to. But if I mention, quitting smoking, and they say, well, yeah, I've been thinking about that, and then there's sort of a kernel of interest, and we can support that. But I also think the flip side of that is that their community is essential, because nobody can change what they do in isolation. So I think whether it's support groups that we've started, and educational groups that we've started developing at our hospital and others, but also work in the community that supports changing their behavior.
Hello.
I think Dr. Lee just had one additional comment. I'm so sorry. And then it's coming.
Yeah, it's just, different things work for different people. And I think that's what we're trying to listen to and hear and embrace. And so maybe it's that relationship with your nurse who's going to call you every 2 weeks to check on your home blood pressure readings, and then talk to your provider to figure out if adjustments need to be made. Maybe that's connecting with a health coach and a nutritionist and a group, because that community that's founded there where people can set their SMART goals and kind of follow up every week may be helpful for some. Maybe that's, having a relationship one-on-one with your provider and their care team. And so I think we're trying to build different opportunities for people to engage, knowing that people are different and life changes. And so if we don't address kind of all the different pillars, like the stress in one's life, and do they have enough food to eat, and do they have a place to live, that we're not really taking care of that person as a whole, and it's hard to change behaviors in that context.
Hello, and thank you for the valuable information that you all are providing. I work at the Brooklyn Public Library at Grand Army Plaza, and I'm the site manager for an adult literacy program where we're working with people that's learning to read and write all the way up to getting their GED. And when we speak about cultural differences and sort of breaking down the barrier, many people of color we know do not take part in trials and things because of history, past history. And so if we can get more information out there into the community and sort of try to reassure people that, we know what happened in the past, but this is where we can go if you can take part in trials. this is what we need to do to make a difference, to be able to find out what's happening and to be able to make a change. And so I know one of the commitments I'm making here is that I'm going to invite folks outside to come to my site and to talk about the importance of the research so that we can debunk some of the myths and like bring the guard down a little bit so people are more willing to take part in this research. Because until we do that, you know, folks are afraid of research because of the past. And so we have to get that veil moved so that we can get people in. And I think that's the only way we're going to be able to do it. So really get into the community and do that a lot more.
So this is
that's my comment.
it's an important question that I would like for the panel to address. I mean, I had this just the other day with one of my own patients. I was discussing Leqembi, and one of the savvy caregivers said how many black people were involved in the Leqembi trial, and I had to say, not as many as I would have wanted to make educated decisions about that treatment. So how can we be better?
I think this is a very important question. I appreciate the question and the way that you phrased it. Because just like behavioral change, it's multi-level. It's people have a desire to change, but if they don't have the support to sustain the change, which is we're here today to provide that sustained support. Then after the intervention is over and the researchers publish their paper, people are coping, and so I think about health behaviors from a stress coping paradigm, with racial discrimination being a stressor, or financial stress, family stress. People engage in unhealthy behaviors to cope and sustain, right? And so we got to understand that connection to really be able to drive behavioral change. So, but multi-level, right? So in terms of participating in clinical trials, there's some research that says that many non-white populations simply aren't even asked, right? So there's this notion of hard to reach populations, and we don't participate. I would challenge that. I think we would participate if we knew all the details of the trial and someone, showed us some respect and came and discussed the trial with us. That's at the participation level. But then many times when we get people engaged and interested, they're deemed to be ineligible for the trial because they have what we call a comorbidity. They have diabetes or hypertension. It doesn't make any sense, right? But they're screened out because they have a coexisting condition, right? And so, that's very frustrating to think that we can get people informed, get them interested, and then they're screened out. And so that has to do, I think, with the funding source. The NIH holding researchers accountable for creating pragmatic trials. That's kind of real world trials where you're accepting people who have conditions that to be a part of the trial. And then FDA, the Food and Drug Administration, is the agency that approves these treatments to be used. I mentioned that they approved two antibodies that reduce amyloid in the brain. Well, the FDA should make representation a requirement of approval. These won't move forward without proper representation. So I think it's a multi-level opportunity for us to advocate for change in policy, get communities information. I do think we've got to talk about the Tuskegee syphilis study, Henrietta Lacks in Baltimore, but then also talk about the protections that are in place now that are different from then. And, quite simply, you can leave at any time. Really reinforce that. And sometimes having a panel of, community family members, people that we know that have participated and benefited, because it's also the benefits. You get a chance to have access to these treatments before they're approved and to be under a doctor's care for your time in the trial. So there are benefits, but we've got to be able to address this from a multi-level perspective.
But how much are we when they step up to be a part of these
Yeah,
trials?
That's the opportunity that we have, at least with the Alzheimer's Association, with our chapters around the country. We're doing that. It's just that we're also doing the policy, we're advocating at a policy level, because I believe that my bias here is that if the researchers were held accountable to do the kind of recruitment that's necessary, we would see a change.
So
And with the eligibility requirements, I think it makes it very difficult for people to participate, even when we get people informed and desiring to participate.
That's why it's so difficult, because there's so much, because of all of that at the top level, where you guys have to get, the bigger heads have to get together and sort of weed some of that out, so that the little folks on the bottom that don't understand most of that stuff can be able to hear you guys and to understand the value of this.
The most important people are the people who should be in the trials.
That's right.
Absolutely.
I think Dr. Wrights has had quite
No,
a
I
bit of
just wanted-
success.
Yeah, exactly. So I just wanted to add like one thing. I obviously agree with everything Dr. Hall said. I think also what the issue really in the last 20, 30 years was that, researchers wanted to do research studies, but you cannot just go on, out in the field and just say, just join my study, right? And the study, just as an example, the study I just told you about, where we really, recruit and assess like about 15,000 individuals across the US. That's a study we wanted to do like 10 years ago, because we knew how important it is. But in terms of the funding application we wrote, we cannot just do this genetic part where we just look for genes. What we need, the first part of the study is really go and talk, to the community, get them involved and tell them about, why participation is so important, what's so important about brain health and so on, and really engage them. And we couldn't get that funded, and that really changed now, and I think it really changed, and the reason that it changed is really that, I think also the Alzheimer's Association raised the awareness so much, and it became so clear, why this is so important. And, so a large part of that is also lack of funding, for research, and I think it's changing now, hopefully changing more, but that's really also what the researcher side needs in order to really, be able to engage the community as much as we actually need to.
I would add just one additional thought from my experience with patients recently in Brooklyn. We have a lot of folks that are willing to participate in trials. They don't want to leave Brooklyn.
Yeah.
The trial has to be at home. And so we're working hard to bring those trials home. I see Dr. Berger has a question, and this young lady has been waiting quite a long time to, yeah.
Okay.
And here too, I'm sorry.
Good
I'm not sure who was
afternoon.
first. Yep, okay.
Okay, you go ahead.
Okay. How are you guys this morning? I'm Charlene Tony. I'm actually from Heights and Hills. I'm a social worker and a community outreach worker. And I'm here with my colleagues. We're all social workers here working at Heights and Hills. And it was very important for me to come here today because this is something that, we service, older adults and also the family caregivers. We work with the family caregiver program. And I felt it was important to actually share the information and resource that we have because answering her question right here, what I do is I do a lot of research as well. Kind of understand the community, and as a person as color as well, it's always good to go to communities, especially the communities that I was raised in, and to make that connection to build rapport and to build trust is very important. Now, as we all know, older adults, even now with the budget cuts, stuff like that, these are concerns that they have as well, and they live in panic every day. Retirement, it's not enough for them. Sometimes they need the extra help from, family members and stuff like that. The family members sometimes get thrown into being a caregiver. Sometimes they don't even identify themselves as a caregiver. So our job here is to provide caregiver support. What we also do is, in all these services that we provide at Heights and Hills for the family caregiver program are all free, by the way. Okay, so some of these communities do not even know about this program. And what my job is to do as an outreach worker is I go out to the communities, which I actually met Betty from Downstate. We was actually doing outreach at Community District 9. We was in a park, and there was a bunch of organizations there with the same goals. And that's what's important for collaboration, and I feel, because that's how we get the information out there. So what you mentioned earlier too, Dr. Michael, was community engagement and education. And that's very important because going to communities, they lack the resource and lack information. And they don't have no trust. The Black community sometimes do not have trust. So it's my job to let them know that I understand that and you're not alone. And the resources where they can actually benefit from. So by doing that, it just makes me happy and it just shows a lot of more work needs to be done. Because, they can tell, we can service this district and we can service this district, but how much people that really just don't know. Not about our organization, about all the other organizations that they can benefit from. So I would love to, collaborate with, people that have the same goal, and that's the main thing. I love what everyone said on the panel. It's definitely a thing where it's a work in progress, and understanding this, what people go through, older adults and the caregivers is very important. And caregivers are under a lot of stress. So for us at the Heights and Hills, we love what we do, and we're going to continue to kind of reach out and do the outreach work and do the research to understand that we have to serve the underserved districts. And that's the main thing I try to service. Not tribal is what I'm doing now with District 16, which is Brownsville. We have East New York, we have Williamsburg, and we also have Greenpoint. And all the other districts as well, but these are the ones that's underserved and just do not have the resources. So I just want to say thank you. And anyone who has any questions for me after this, I have some pamphlets, and I would love to just give them out as well. So I just want to say thank you and continue to do the work. The work is amazing, and I love to see the growth within the colored communities.
Thank you for the work that you all do, and thank you again for mentioning caregivers, one of my favorite groups of people, and it's a group of people that also deserves consideration in our research efforts. And any comments from the panel? Oh, we had a question over here, and then we're coming back.
Okay. So my name is Yolandi Latham, and I have a company I'm based out in Long Island. It's All Pro Health Staffing, but so that's just my business. But I'm a nurse by profession, and I lost my mom to dementia in 2019. And while I'm a nurse, and I had done a lot of work in traumatic brain injury, so I have a good understanding of cognitive loss. But when it's close to home and it's your own parent, your medical information goes out the door because you're losing your parent. So in losing and going through that situation, one of the things that I did was I connected with the Alzheimer's Association of New York. My parents live in Canada, and I'm the only one of 4 that lives here. So you had that guilt of being the one that's away from home and not being there to help out as much as I would like to. So education for me was my way of trying to do what I could do, because one of the biggest things for me was thinking about the day when my mother would no longer remember who I was and how I was going to handle that. So getting involved with the Alzheimer's Association, it's a huge organization, and this is a multi-pronged problem that we have here. And it's a public health issue. That's how I see it. And at that state level where they're lobbying for policy change and all those other things, in the meantime, those things don't happen overnight. There's so much levels that it has to go through before something is passed. So we will never see quick change, but if it's slow and steady, at least we're getting somewhere. On an individual level, as people in communities here or in the United States, we can find a way to do the things that we can do to reach people who we are connected to. So for me, one of the things I do is I do dementia care certification training. And I've had the opportunity, I've had groups from VA hospital and things of that sort come to me and attend the training so that they can certify their staff. And I've seen a tremendous increase in interest in assisted livings and nursing homes and other places where elderly people are getting these certifications so that they can learn to provide better care. So I think that not only should we just be focusing on the long-term care, but it should be something that is broadly taught to nurses all across the board, which I teach to the nurses that work at my company because I can, but it should be something that's offered widely. And in addition to that, we need to also get to a point where we're educating law enforcement about how to deal with somebody and how to approach a situation the right way, how to connect with somebody before they make bad decisions on handling someone in an incorrect manner. So as, I can't remember your name.
Mike.
No, the lady beside you.
Miss Macy?
Miss Mason, as Miss Mason had said, education is key to all of us doing our part, and everybody should do what they can do at their level. I'm doing my small piece, she's doing her piece. The people who are at the policy level will do their piece. The other people who are in the Senate will do what they have to do, and hopefully we'll all come together. In the same manner that we were able to work on smoking, and smoking is not good, as a public health issue, and now I believe that smoking is not so cool anymore because of all of that was done, but that took a long time to get to a point to where we are today. And in the same sense, we need to continue that with this fight. Thank you.
And it took a village. And you brought up some really important points. There are states in which there is mandated education on Alzheimer's disease and related dementia for licensure, Massachusetts being one of those. Any comments from the panel? Policy initiatives?
Well, I'm just, total agreement, and just the synergy of two things that, when you're in DEI and we're advocating for inclusion in the trials, your association is advocating for also that CMS cover the treatments. So there's a way of looking at this to say, well, there's no representation in the trials, we don't want them covered, right? But that's not, the point is, we're working at multiple levels at the same time trying to accomplish, I think, access and for all people and representation in the trials as soon as possible. So just, I like that multi-level, multi-pronged issues. Yeah.
Couldn't agree more. And I think we have time for one more question, and then we may wrap up with final comments from our panel.
Good morning, everyone. My name is Stephanie Wilson, and I must say thank you to all those that are on the panel, Dr. Hill, for all the information about Alzheimer's and dementia and the different levels of Alzheimer's that could go into also dementia. Ms. Macy, I want to thank you so much for the work that you are doing in our community as a member of one of the older club members from the Blenman Center. We know food, diet, and nutrition, exercise. Recently, they started the walking club, in which the older, I should say not saying seniors anymore, the older club members engage in walking activities. And we got to remind ourselves, we are on so many different medications for blood pressure, for diabetes, and other health issues. But we have to remember the resources that comes out to our community for education. Educating the older ones is so vital, is so important. Educating the home caregivers are vital and so important. Educating nurses, as the nurse said, educating nurses goes a long way. We know that we all are members of churches, and churches is a big organization. And I believe that in the communities where we have more, in the Black communities, and also the other interracial communities where they have churches and synagogues, that these educational activities and the resources that comes through these institutions from the political areas, arena I should say, that puts into these churches, that education, the members of the churches who are professionals in these churches can go forth into the communities where they can be able to deliver the resources by education so that the people can be well educated to take care of themselves. So once they are educated and they are receptive of what they're being taught, we will see a greater influx of wellness that they will practice. Ms. Macy and the 13 or the 14 centers that is under Ms. Macy's, we know that from Downstate, we know Dr. Reinhardt and the other members who comes to these centers and deliver. When I say they deliver to the older club the resources that they need in educating them in wellness. And I want to thank you all again. And I must say again to the panel, thank you for having such a great conference today. Thank you.
Thank you. So I think there was one, you said lots of great things, but I just really wanted to say thank you for this idea that, you know, often we think that the academia goes to the centers, goes to faith-based organizations and provides our education, but you pointed out something really important and near and dear to me, that those organizations have so much of their own strength, and that can be leveraged and brought out to the communities and amplifies everything, right, from educational initiatives, and that's so vital. Thank you. I think we have to just close. I apologize. Oh, sure.
First of all, completely amazing in so many different ways to have a gathering like this with the same, intention and talent behind it. This is the start of like a lot of conversations and ideas. Is there possible to have a thread started, email-wise, so that people can share ideas, examples, questions, thoughts, so that this can continue and not just end at this point?
We would love to do that. We can talk with our partners and find a way to, thank you for saying that. Parting words, big issues that you're going to tackle this year, number one thing that you're going to work on, parting words of wisdom from the panel.
We're ready to part. Okay, I just want to say this was very educational, informative, and like the gentleman said, I agree with that. I know it's going to put more on your plate, and if I had money, I'll fund it. So that we can, since this is so big here, that we can work with the Alzheimer's, and we can do what we want here, but in order to get it to the policy level, we have to start, raise noise, advocate, local level, starting with our city councils, etc., because the laws that they have for funding, and this is just my take on it, I tell everybody, this is what the survey said, this is the report said. First, you have to ask yourself, who funded the research? And what was the outcome? Was it backed by Dr. Reinhardt, who's prejudiced about something? And so are we getting it? Sorry, I'm a radical person. But it's a fact, because I just get angry because community of color is not only black, it's non-blacks. So we can sit here and talk, but we cannot go home and sit at our desk and say, I don't want to be on TV, I don't want to get in trouble, I don't want them to burn in my house. Martin Luther King and everybody else, for us to be here more than Martin Luther King, we are looking forward to Dr. Hill's organization to lead us to this fight, and I'm ready to go to Washington. Call me anytime, because if we don't do it, who's going to do it? And everybody say, yeah, it was a nice seminar, and I agree with you. If we can start, everybody to register who want to be a part of it, and so by the time your program is finished and ended, you would be the one, Downstate, that had started this, and we're ready to go march, because it is a fact. And I can go on, but we have to be in the trenches, walk the walk, don't be scared, in order for us to get this disparity in having services on Alzheimer's. Thank you.
To borrow phrasing, we have to act on Alzheimer's. Thank you, everybody. I'm going to invite Doris or, yeah, okay. Thank you.
Excellent. So again, thank you all here in person and virtually who joined us here today. When we came up together with our two organizations convening and thinking of this conference a month ago, we knew it would only be one step in all the work that we know that we need to do together here in community. One thing we want to make sure that folks in the room and online are available to you, and we'll send it out afterwards, but is knowing what resources you can connect to in your community, not only through the CBOs, through the research institutes, but through the two host organizations that we have here. At the Alzheimer's Association, we offer education programs and community awareness efforts. As you heard earlier on, we're funding the research. We're trying to walk the walk and do all the work that needs to be done to make a difference. Our advocacy work is a big piece of what we do in engaging advocates and volunteers at the state, local, and federal level to change policies. So that's another way that all folks can get involved. And we have our events, our community events like the walks that you heard Dr. Berger talk about. Is that where you're going to be? Excellent. Early on as ways that you can stay in touch with us. So as Dr. Berger does his final plug, I'm going to pull up a list so you can see those resources again here. And for individuals that you're in contact with, I know many people here are representing a health system or a community organization, but as an association, the best phone number that we can give you is that for our helpline, because it is a great resource for individuals, researchers, caregivers, anyone who needs to talk to someone 24/7, up to 200 languages available in terms of translation. So if you need resources and you or someone you know needs to be connected, it is the one-stop shop and the best place that you can get connected back to your community. So thank you so much for coming today. Thank you, Dr. Berger and Downstate team for hosting us, and you have the final word.
So, who has been energized by this morning's presentation? Raise your hand. Who wants to know what they can do to make a difference? Well, I'm going to give you something really simple to do. Really simple. And Ms. Mason has teed it up by saying we need to march. Well, October 29th, 2023, is the Brooklyn Walk for Alzheimer's. All you have to do is sign up to walk, put together a team, join the Downstate team, but come out and walk and show how important this is. And one thing I want to point out for everyone in Brooklyn, Brooklyn has 2.7 million people. Manhattan has 1.6 million people. Manhattan raises over $1 million for their walk. Brooklyn only raises about $230,000. Brooklyn can do better. Downstate has been one of the largest fundraisers for that, and I thank Betty Young and Sarah Marshall for their work on the Downstate team. But if you want to do something and you're not sure what you can do, the simple thing is come out to walk and show that you support the mission of the Alzheimer's Association.
And that I will say at the registration desk where you checked in and at the Alzheimer's Association table right next door, there is a QR code that was on a slide that has somehow disappeared that you can scan on your way out that will take you to the registration page for the Walk to End Alzheimer's. But the other piece, as I referenced, I want to make sure to leave this as the final piece, because while it's up to all of us to be part of a movement to make a difference, there are people struggling with this right now, as we all know. So please know that we are here for you. This is how you can reach out to us. This information is on all of our resources out at the table outside. So again, thank you all for coming. Thank you again to our panelists, to our host site, most importantly, all of you, and have a great rest of your day.